I start with this question here, because my job today here is to ask some of the fundamental questions, I think, that you have all heard before in the previous talks, but I like to sharpen this argument a little bit. This symposium has been long overdue. This is the idea behind my talk, and Marc Humbert may appreciate that in particular. Pierre Tyler Desjardins has been recognized lately in the last couple of years by the Catholic Church as somebody who does not have to be vilified anymore. He was a paleontologist, Jesuit, philosopher, thinker of the highest caliber, and he said everything is the sum of the past and nothing is comprehensible except through its history. So we're talking about evolution here. When I started in the laboratory that has formed me a bit, I was fortunate enough to write a textbook chapter on primary pulmonary hypertension with the late Jack Reeves. And these are his words, these are not mine. I reference it like that. And he wrote, the association of primary pulmonary hypertension with collagen disease and Raynaud's phenomenon suggests that the disease is part of an immunological process. Yet, we found no published reports bringing the methodology of immunopathology to bear on this disease. This is 1979. We can go actually back further. Due to the vigilance of Horst Olszewski from Graz now, he alerted me to what I think is the very first report of idiopathic pulmonary hypertension described by a pathologist in Vienna. And the title of that paper is Endarteritis pulmonalis deformans. And this is my translation. I apologize for that, but I thought I'd do that. Professor Kolb wrote, on inspection, the lungs are bloodless, and microscopically, the vessel lumen is narrow, and there's a massive increase in the thickness of the interior layer of the vessel because of growth of a pseudomembranous connective tissue neoformation. Here you have it. Next comes Donald Heath, who, together with Jesse Edwards in Minneapolis, is responsible for the classification of the pulmonary vascular lesions. And he was also responsible for focusing on the mast cell first. This is now 1967. He saw these mast cells in all of the pulmonary hypertensive lungs, included patients with mitral stenosis. That led to a cellular concept for the first time in vasomotor tone control in the lung. And this is from a paper by Bob Grover with Michael Kay, showing the correlation between the media thickness that you get with chronic hypoxic exposure in the rat and the number of mast cells. And that was, a correlation, and everybody said, okay, that there has to be something important about that. The people not far away here, the CVRI, Norman Staub and Anton Hauge from Denmark, were thinking about histamine as being the mediator of hypoxic vasoconstriction, and that went on for about 3 or 4 years, and actually that was the trigger factor that got me interested in the lung circulation. 1979, in May, in Washington, D.C., Bengt Samuelson connected slow-reacting substance of anaphylaxis with the leukotriene pathway and proved that it was leukotriene C4. So this is going on for quite a long time. I've been in that field for a while, and it's been a long time. This is a paper that Kurt is fully aware of, published in 1983. Leukotriene C4 and D4 in neonates with hypoxemia and pulmonary hypertension. And you have a little bit of a timeline here following that. Inhibition of the 5-LO activating protein reduces pulmonary vascular activity. And then here, that work that mostly Ruben is responsible for, 5-LO and FLAP immunoreactivity in the lungs from patients with primary pulmonary hypertension, localizing the 5-LO to the endothelial cells. And this was a very contentious issue at the time because endothelial cells were not supposed to make leukotrienes, but they were expressing the enzymes, and later on we could show that they do. So I mentioned this paper that Marc Humbert already mentioned. I think this is still a landmark paper of Ruben's exuberant endothelial cell growth and elements of inflammation are present in the plexiform lesions. And it says down here, our findings indicate that the plexiform lesion may result from a deregulated growth of endothelial cells. The presence of perivascular inflammatory cells suggests that cytokines and growth factors may further influence the development of plexiform lesions. This is an image showing you where the B lymphocytes are clustered in the vascular lesions, and it doesn't matter whether it's a patient with congenital heart disease associated pulmonary hypertension or idiopathic. It looks exactly the same. And one idea is that this is the lymphatic space here, and that the cells are coming through the lymph system and are localized here. This is not totally new. This goes back to about 1968. This is by Kees Wagenvoort, showing here the amassment of inflammatory cells in a 13-year-old child with unexplained plexogenic pulmonary hypertension. Here now we show Charles Di Novello, the father of the interleukins. Note the first paper that talks about interleukin in the context of malignancy. Marc Humbert went to take these interleukins seriously and looked for them and found them, and this is 20 years ago. Other cytokines can be found in these lesions. In this example here, we worked with Charles Di Novello, and we found interleukin 32, which we think is angiogenic and causes endothelial cell proliferation. So why have we all been so slow? The purpose of this timeline, of this historical overview, is just simply to tell you that it is time for action, I believe. And this is your question, Mark. Is inflammation cause or consequence of severe pulmonary arterial hypertension? I'm very sympathetic to this question, but I believe it has blocked us from going forward and move into the clinic. So this question is, of course, intellectually very pleasing, but it's pragmatically wrong. Instead, the question should be, does treating inflammation improve outcome? And I think we are at a time where we have enough lead ideas, lead hypotheses, and also lead drugs so that we can actually go forward and test some of these things. There are so many questions that are very basic still. Is inflammation and pulmonary arterial hypertension perhaps immunosuppressive? In my book, since the discovery of HIF-1 by Greg Semenza, I connect hypoxia and inflammation and equal. This ends up with the transcription factor that will cause inflammatory signals to come out. This paper already had been mentioned, I think, by Mark Nichols, and was of interest because of the issue of the BMP R2 receptor problem. And the data are shown here. If the haplotype animal was also infected, in this case with an adenovirus 5-lipoxygenase to increase production of leukotrienes, there was a clear-cut signal in terms of increase in pulmonary artery pressure, right ventricular systolic pressure. That connects with what Mark Nichols showed before, serum levels of LTB4 in patients with connective tissue disease, mostly scleroderma, I understand, and also idiopathic patients. This may be a way of selecting patients for treatment. Those patients that have that signal may benefit from particular treatment. And I think, without being critical, that can be improved by looking at a stable urine metabolite, because that will give you much more of an integrated production over 24 hours or so, the amount of this inflammatory mediator. This is for you, Mark Nichols. Leukotriene A4 metabolites are endogenous ligands for the aryl hydrocarbon receptor. And I bring this up because I think in our discussion, this interface between immunology and vascular pathology, there is that missing link of this particular concept of aryl hydrocarbon receptor triggered responses. This is taken from a recent review article, and you see that this aryl hydrocarbon receptor that is activated by dioxin is also connected, of course, to the cytochrome P450, drug metabolizing enzymes, to cyclooxygenase, to arachidonic acid, and that there is a feedback between arachidonic acid metabolic products, prostaglandins, leukotriene, and activation again of this aryl hydrocarbon receptor. In 2008, this particular receptor started to enter main stage. There were several Nature papers. This is one of them, the control of Treg and Th17 cell differentiation by this receptor, metabolic control of type 1 regulatory T cell differentiation by aryl hydrocarbon receptor and HIF1 alpha. Connects toxicology, drug-induced vascular disease likely, with inflammation and with immune regulation. Sugen, the inhibitor of VEGF receptors, is a ligand for aryl hydrocarbon receptor and is equally potent in terms of inducing this receptor and signaling throughout as the dioxin. So I show you this Bermuda Triangle here now, which looks at hypoxia and shear. Vasoconstriction is shear, hypoxia is inflammation, toxins and drugs, and the immune response regulation or dysregulation. And in the center of that particular triangle is the aryl hydrocarbon receptor and ARNT, which is HIF1 beta. This paper Mark referenced before, I just want to show one particular image of that. This was done in the mouse by Gabi Grunig mostly, and you can see here the enormous muscularization that you could get in the mouse with a ovalbumin sensitization and immunization paradigm. The fly in the ointment was that there was no increase in pulmonary artery pressure, there was no right ventricular hypertrophy, there was only that stunning remodeling muscularization of these pulmonary arteries. And this leads to this hypothesis that focuses again what both of the Marks have told us about here, where you have a T17 arm that promotes the muscularization but may do nothing to the endothelial cells, and you have a Treg controller that prevents endothelial cell proliferation. So there may be packaged in the lymphocyte mechanistically this dichotomy, promoting and protecting and preventing. So not to be too analytical and critical about the state of the field, why we are where we are today. I think that in part it has to do that the different disciplines, faculties that are supposed to interact on behalf of pulmonary hypertension patients and pulmonary vascular diseases have just not enough overlap of background, commitment, and resolve to really solve this problem that we've been knowing about for 25 or so years. And there is, as has already been alluded to, a lack of a strong belief that the inflammation and immunity are really central, important, or whether they are just a consequence, in other words, the shadow of the ghost. And this is the fundamental issue that we are facing. We have to get over this. So, is the challenge for all of us that effective pulmonary arterial hypertension treatment is entirely in the reversal of angiobliteration? I think that's a key question. What about the right ventricle? Marc Humbert alluded to inflammation in the right heart. I agree with that. We've published a microarray gene expression survey of the failing right ventricle and found numerous inflammatory signals, cytokine receptors being upregulated. We know that the myocardium is full of mast cells, and we also have to think that the microcirculation, the microvascular endothelial cells in that myocardium is also participating in the disease. And I was very pleased yesterday to hear about experiments going on here that look at the interface between the microvascular endothelial cell in the heart and lymphocytes. So, to some degree, I think many people believe that the vascular disease that sits in the lung is not in isolation, cannot be seen in isolation, but more in a system context where we have postulated that the sick lung circulation releases information that is then being read by the myocardium. The heart, in turn, has a secretome. It secretes certain things. This growth differentiation factor 15, for example, can be measured in blood and has also been localized in the plexiform lesions. We affect the kidney, the adrenals. Vascular endothelial growth factor, which is elevated in most patients, is a fantastic activator of bone marrow stem cells. And so we have a circuitry that may also be strongly influenced by the immune system condition. So treating the inflammation element in pulmonary arterial hypertension, if we want to move in this direction. What are the assumptions? One, that inflammatory mechanisms are really of critical importance for the maintenance of the pulmonary vascular abnormalities and for its progression, and that there is or that there are hubs that can be targeted without jeopardizing the defense against invading organisms. I think this is a concern with any kind of immune modulation, that in exchange for having perhaps an anti-inflammatory response that is valuable, you might also invite problems in terms of infection control. This is my plea. We have been in the last 25 years up and down the staircase. And at some point in time, once we get a bit more elevation, we are just seeing the problem from a little bit more elevated level of knowledge. But it's time for us to address some of the questions that I hope you can be convinced are dear to my heart. So, anti-inflammatory treatments that we can do right now that I think should be implemented and tested. I think prostacyclin is an anti-inflammatory agent in severe pulmonary hypertension. We believe that carvedilol, not because of its beta receptor blocking, but of the other effects that the drug has, is working as an antioxidant, anti-inflammatory agent, affects NF-kappa B, TLR signaling, etc. And that is only affecting the myocardium, we think, has nothing to do with the lung circulation. And another one here is spironolactone. I think there is a trial in progress, at least has been designed, to use spironolactone, particularly because of its anti-inflammatory effects on the heart. So this is what I want to conclude. In pulmonary arterial hypertension, the immune component of the disease is part of the response to vascular injury. And the paradigm that I want to leave you with is, in terms of pathobiology, the wound that does not heal. And perhaps the ligand-activated transcription factor, a real hydrocarbon receptor, controls Treg and Th17 immune homeostasis. And if so, it would link the xenobiotic responses and immune dysregulation. In other words, it would connect what we see with drug-induced pulmonary hypertension, where we have a whole issue of interesting studies to do with inflammation, with hypoxia, and with autoimmunity. Thank you very much. Well, it wasn't intended to silence you all.
Yeah, that's my fault. I didn't get up here. But I wondered, maybe I could ask a quick question, which is just to take you back to the history. So you told us about the long road and all the things that, in a way, were overlooked, right, and that took us so long. But was there work that caused the delay? In other words, did people have reasons for not pursuing this idea sooner?
I think, in my mind, the community continues to be frazzled and occupied by this question, cause or consequence. And you can, if you sit there on that level of asking questions, you will be enamored by another cytokine pathway, by another signal transduction pathway, and find all of these things out, but you will not get into the clinic where we need to be and test compounds that we perhaps already have or already had. Example, diethylcarbamazine was shown almost 30 years ago to affect the development of chronic hypoxia and monocrotaline-induced pulmonary hypertension in the rat. That's a drug that's available. It's used worldwide successfully for the treatment of filariasis, a hypereosinophilic syndrome. And the target there were eosinophils producing leukotriene C4 in particular. Bestatin has been around for quite some time, and the credit goes entirely to Mark Nichols to drill down on this particular eicosanoid metabolite and open up, in my mind, a whole new vascular biology to show that LTB4 causes apoptosis of endothelial cells. In my mind, was a breakthrough. There are other things in the lab that are amounting to a breakthrough as well. LTB4 until then was considered a chemotactic agent for neutrophils. Book closed, thank you, that's over. We know that LTB4 will have the neutrophils march into the lung and then they do their bad things. But the fact that they can also now, in that paradigm of pulmonary vascular disease, induce endothelial cell apoptosis and perhaps phenotype switch of these cells, affect smooth muscle behavior, is something that is really ready to be tested in the clinic now. And so he started the rituximab trial that initially we wanted to be done in patients with idiopathic disease. The steering committee said, no, this is this is not good, we don't understand idiopathic pulmonary hypertension, let's go with scleroderma, right? And so that is, in essence, my message. If we have a meaningful concept, a good rationale, and we have a drug that is mechanistically appropriate and applicable to this paradigm, let's take it to the clinic.
Norbert, I guess my question for that philosophy is, if we all agree that there are both beneficial and detrimental immune responses in the disease, and we all agree, as we've been discussing, that there is heterogeneity in the patient population, so that different individuals are going to have different defects or alterations in their immune response, which are important in the progression or the inhibition of the disease, then when you do therapies, and presumably this is why there was not seen to be great benefit of total immune suppression or extreme immune suppression, and because we need to be much more sophisticated than that. So how do we do, at this stage of our understanding, how do we know who to target with which types of therapies?
Yeah, I would agree that this is not going to be one shoe fitting everybody. But we already know for quite some time that there are patients that are having a high level of interleukin-6. Let's go and start that as a target, as had been mentioned before. I fully agree with that. There are patients that have very high level of LTB4. Let's look at that. And if one can think about a immune reconstitution program based on regulatory T cells, that is something that we need to try. So there are, I think, both opportunities right now for broadly applicable strategies like working on the Treg cell, but also then specifically to find out whether the IL-6 really matters in the outcome. So this is where we are, and I think instead of, as we are thinking about this issue of cause or consequence, early intervention, yes or no, when is it too late? You have a patient with totally sclerosed vasculature in the scleroderma patients, including in the microcirculation of the heart. Is there anything going to work at that stage? We all can ask these questions now. They have to be tested in the clinic.
Well, I would suggest, and I think the reason that I love so much Edda's and Marlene's and Roham's focusing BMPR2 and a targeted therapy towards BMPR2, because that is something where we can all agree in a subset of patients that is the key causal effect, and the drugs are going after that. So what I would ask, and I like the idea of having an index case here, a one that the community can focus on, is where, in terms of the immune, in individuals with immune disease, is there, for example, a good evidence that there is a single immune genetic cause for the or a contributor to the disease that can go after and target it, because we all agree that the immunology is just progressing right now, and it's hard to sort out exactly where to go after it. If there was a subset of patients where there was a genetic defect that is well documented in an immune modulator, then I would suggest that that might be a good case to go through. Maybe it's IL-6 if you think the data is good enough on that.
Yeah, in as much as the BMPR2 haploinsufficiency fosters inflammation, and perhaps also, as we don't know yet, alters the immune response of the individual, okay, directly by itself, because this disease of haploinsufficiency or that problem may not just be housed and reside entirely in the lung circulation. So the idea that defect by itself could also affect the immune modulation I think is also an important one and could go in the direction of Edda's treatment. I mean, I just want to make one more mentioning of this aryl hydrocarbon receptor thing. One of the first observations of interest was that when you gave animals dioxin to really upregulate this system of aryl hydrocarbon receptor, which then through ARNT becomes a transcription factor for a multitude of genes. One of the first things that the investigator noted, Mark, was thymic tissue going away. They turned with the dioxin by activating the aryl hydrocarbon receptor, they turned them basically into an athymic animal. So I thought I'd bring this up because I think this is a missing link in our field where we don't know yet how many toxins or drugs are actually out there that are causing disease in our patients. And Mark Humbert is taking the lead of basically have implanted a FBI agent in his department that has nothing else to do but searching for potential drug and drug interactions. And that's a very important thing to do. So that's why I make this case.
We're going to let Ron ask one very quick question, and then we're going to take a
One very quick question, Norbert. I know you like to be provocative, so I'm going to be provocative. This is a terrible disease. When we think about immune reconstitution, bone marrow transplantation for patients with pulmonary hypertension, where would that take the entire field? Or is there a role for a dramatic approach such as that? I tell you that because we did that with Ramona, who's in the room, on a patient who had lupus here about 10 years ago, who was on the brink of transplantation. She received a bone marrow transplantation and hemodynamically had some improvement initially, but she lost her graft at that point and went on to transplant UCSF. So are we thinking about medical therapeutics, or can we understand from oncology other forms of approaches as dramatic as a bone marrow transplant?
I don't know. I don't know much about the bone marrow. This is one of the things that needs to be more explored in the context of this disease. But I would agree with you that as physicians that are treating these patients, we need to be much more gutsy and take on attitudes from oncologists that are treating patients that they know have only a certain time of survival, and this fits our patients. I mean, we have basically collectively extended for idiopathic pulmonary arterial hypertension the survival time with therapy out to 5 years or maybe 6 years. But then things are starting to get out of control. So why is this different from a woman with stage 2 or 3 breast cancer? I don't know. It is not. And so if we can think about an immune modulating therapy, or one can conceive bone marrow transplant as an option, we have to start doing that. And we have to learn from that as we are continuing to look at the fine points of the immune disorder.